Hello, everybody. This is Lisa Johnson from Everbridge, and welcome to today's webinar, Billing for Telemedicine. We have our speaker today, Ranya Habash, is joining us. Thank you very much, Ranya. And we are sponsored by the SFMGMA group down in Southern Florida. We'll be hearing a little bit from them as well. So our agenda for today, we're just going to do a little bit of housekeeping. I'll introduce Dr. Habash. We'll do a little bit of a history of telemedicine and how telemedicine is being used today. We'll go over HIPAA Bridge and how HIPAA Bridge is being used. And then Ranya was lucky to be part of a study with the Mayo Clinic, and we'll cover that and how telemedicine helped speed door-to-needle time for patients. We'll also be going over some commonly asked questions for telemedicine, and we'll be talking about the recent decision on texting orders from the Joint Commission. We'll have a wrap-up section, and then we'll also take questions. So let's introduce Dr. Habash. Ranya was named to Castle Connolly's Elite America's Top Doctors list for 2015, which represents the top 1% of physicians in the nation. She began a successful career as the elected president of the Palm Beach County Ophthalmology Society and gained further acclaim after the state's Florida Society of Ophthalmology named her Young Ophthalmologist of the Year for demonstrating leadership, service, competence, and devotion to the highest ethical standards and professional standards. She was then asked to serve as a board member and president of the FSO, the governing body for all ophthalmologists in the state of Florida. Dr. Habash was recently appointed to join the faculty of Bascom Palmer Eye Institute, the top eye hospital in the country. As a fun aside, she is the official eye surgeon for the UFC organization, providing surgical and trauma care for the MMA fight champions. I'm sure you've seen some stuff there, Ranya. And then I would like to introduce Jessica Garcia. She is from the Southern Florida Medical Group Management Association, and she's just going to say a few words about what the SFMGMA does.
Good afternoon, everybody. Firstly, I would like to go ahead and thank Everbridge and Dr. Habash for putting this together and offering some valuable information and resources to everybody on the webinar. Just to give you a little bit of background, the Medical Group Management Association is a national organization that gets broken down into state and local chapters. We are the South Florida MGMA, and we are the local chapter for Miami-Dade, Broward, and Palm Beach County. We are geared toward providing networking and educational and developmental resources and availability and opportunity to this region. And if you'd like more information, please visit us at sfmgma.com. Again, that's sfmgma.com.
And we are going to switch, I'm going to switch my screen over to Ranya.
Okay, so I thought we'd start with a brief overview of telemedicine. Everyone thinks this is a very novel concept and a new thing, but it's really not. If we look at, just look at the little meme on the left-hand side there, this is an actual screenshot from the Jetsons, which was from 1962. And it shows a telemedicine visit. Even back then, it was projecting the use of telemedicine. Again, that was from 1962. There are a couple of fun facts I wanted to share with you guys just to show you that, you know, telemedicine is not a new thing. We can go back to the last slide. Yeah, and you know, you guys should hear some of these funny facts that go along with telemedicine. One fun fact is that smoke signals were the very first form of telemedicine. African villagers used to use smoke signals to warn others to stay away whenever there was a serious or infectious disease ravaging a village. So it was a very common practice in African tribes. So that was the very first form of it. Prisons have used telemedicine heavily since the early 2000s, actually. California prison systems provided over 9,000 telehealth consults in 2004 alone and saved taxpayers about $4 million in transportation and escort costs for the prisoners. Another fun fact I had was that patients will make very bizarre sacrifices for telemedicine. There was a recent Harris poll and FICO survey that 80% of patients want to use their mobile devices to interact with and have access to their doctors, and they're willing to make sacrifices for it. So what kind of sacrifices? Our statistics, or the Harris poll statistics, showed 30% would skip shopping for 1 month, 9% would forego their next vacation, and 5% would skip showers for a week. So those were the kinds of things that people were willing to do to have access to their doctors just via their mobile devices. So what are the best use cases for telemedicine? Now, everyone is going to have their own use cases, but I can tell you what works in my practice and what I found that works in other people's practices as well and in our hospital systems. Consults are a very, very important use case for telemedicine. You know, I can't tell you how many times I get consulted from the ER and they tell me patient has a red eye, and there's no other information, and I'm stuck in clinic and can't make it down to the ER to triage the patient. Meanwhile, that poor patient is waiting there for hours, and we all know what happens also when a patient waits in the ER. The ED throughput time goes up, and it's costing the hospital a lot of money. So it's just not a good situation for anyone. But I started doing telemedicine consults via HIPAA chat or HIPAA Bridge instead, and helping the ER doctors triage these patients, get orders started, get them admitted, get them discharged to my office, whatever needs to be done. But I think consults are a great use case for telemedicine. Patient follow-ups are also a great use case. There are many times, you know, I'm an ophthalmologist, there are many times when a patient comes in with a sty or pink eye or something like that where they need to be followed up in a week, but hey, they're better or they're feeling better, and it's not something that really requires a trip into my office. And that, you know, 1 hour wait in my office along with any transportation time and time off work or babysitters or whatnot. So on these patients, these quick follow-up visits, I make the decision that they're amenable for an e-visit or an electronic visit instead, and offer them telemedicine while they're at their desk at work or while they're at home with the kids. And my patients love it. You guys heard, you know, what I just said before on the last slide. You know, patients are willing to make huge sacrifices in order to have this kind of technology. Patient check-ins like mental health, behavioral health and mental health, and wellness checks are very big use cases. A lot of our mental health providers are using it as a tool to check in on patients weekly, for instance, make sure they're taking their medicines, make sure they haven't had any suicidal thoughts. It's very important for behavioral health and monitoring. A lot of these patients can't or don't want to come in to see their doctor, and will open up a whole lot more if they're sitting in their homes using a mobile device. Patient transfers are another, you know, I think very, very important issue for telemedicine. Going back to what I was mentioning before about consults, this occurs with outside facilities as well. There are many times, you know, being at Bascom Palmer, we get so many patients transferred from other facilities. And a lot of times they're transferred for things that don't need to be transferred. And, you know, they've just cost that patient so much time and money by being transferred and put a big burden on the health system. The flip side is true too. There are patients who really need to be transferred. They have ruptured globes or, you know, major emergencies, and they're not transferred appropriately. So if we can triage these patients from, you know, from the hospital system or from our offices, then we're doing everyone a very big service. Transfers cost the hospital about, you know, about $10,000, I guess, per transfer if the patient is uninsured. And so that's a lot of money and time savings that we can give to the hospital systems and ourselves. For patient monitoring for chronic conditions, clinical trials, those are really important as well. And there are some reimbursement codes for chronic condition monitoring, which we'll go into a little bit further. So how common is telemedicine? I think it's kind of important, you know, just tying back to that last slide, that you know, everyone, of course, is kind of reluctant to be the first adopter and early adopter to any technology. But, you know, at this point, we really aren't early adopters at all. In fact, you know, it's our that we're behind the curve if we don't have telemedicine or we don't offer our patients telemedicine. The number of virtual visits in the U.S. went from 1 million to 1.2 million over the past year. The percentage of providers that have telemedicine programs, you can see here, 72% of hospitals offer telemedicine now, and 52% of physician groups offer telemedicine. And that's huge. So, you know, it's a 50-50 thing. If you're not offering it, you're in the 50% that needs to kind of get on track and get on the ball. And if you are offering it, that's great. You know, you're one of the main people who is. The percentage of large employers offering telemedicine benefits is growing as well. You know, this is becoming more and more commonplace with big employers. Everbridge has, you know, some major employer systems that offer telemedicine to their employees. And the reason is they don't want their employees to, have to leave work to go to the doctor and leave for the entire afternoon for a doctor's visit. And so they're offering telemedicine as a benefit to keep patients or to keep employees in the office and working when they can. We can go to the next slide. Okay, this is a very meaty slide, but it's about the top, 10 facts that I'm sure everybody is dying to know. This is probably going to be the majority of what we talk about and where your questions will come from later on. Telemedicine parity laws. A parity law basically just dictates that, if your state has a parity law, then your private payers have to reimburse you for telemedicine. There's no two ways about it. If you have one, it has to be reimbursed. There are 32 states plus DC that now have parity laws, 8 more on the way. Now, I know this is the South Florida MGMA. Florida does not have a parity law, which means that private payers do not have to reimburse us. But this is also this is on the table for legislation right now, so it's any moment now when it will become a true parity law. However, the payers still do pay. It's just that they're not obligated to pay every single time. The big 5 cover telemedicine. That's Blue Cross Blue Shield, Cigna, Aetna, Humana, and United Healthcare. So any of these payers should cover telemedicine most of the time. Now, I'll leave you with the caveat, because there's no parity law, there are certain segments of plans, like a Blue Cross Blue Shield, gold plan may cover telemedicine, but the silver plan does not. So the best way to tell if they do or not is to verify a telemedicine coverage by calling the payer directly. And it's one phone call to each of these 5 payers, and you can ascertain which ones will pay and which caveats are excluded or whatnot in the state of Florida. So I think it's something that whoever handles your insurance should be able to do very, very quickly and kind of get those guidelines for your offices. What constitutes telemedicine coverage, or what kind of telemedicine service is covered? This has to be live video, and it has to be live HIPAA compliant video as well. It cannot be a telephone call. It cannot be patient sending a text picture of a rash or anything like that. This has to be a live chat video call that's HIPAA compliant. Incidentally, that is exactly what HIPAA chat delivers. That's why we're one of the reasons we're having this talk right now. Reimbursement is for any E&M service. So you can list any single E&M code, a CPT code, and that can include a new patient code, a consult code, mental health codes, and chronic care condition codes. All of those should be reimbursed. There is no restriction on the location of the patient or provider like there is with Medicare. The patient can be at home, at work, at school, whatever, and you can be wherever you want as well. You don't have to be in your office. You can be at home also and still get reimbursed for the telemedicine visit. The coding for the telemedicine visit is to use the CPT code along with the GT modifier on the end. And that GT modifier is what tells the insurance company that this was a telemedicine visit. Reimbursement, I'm sure everyone is expecting that they won't get paid the same amount, but you do. Reimbursement is 100% of the code billed, exactly the same as an in-person visit. And the future telemedicine reimbursement looks bright. There are private payers which run these large telemed pilots all the time for analysis to see how cost-effective it is for telemedicine, to provide telemedicine services. And they're finding that it really is very cost-effective. It's saving them as payers a lot of money by having patients do telemedicine visits. So they're more apt to pay and pay more over time. I alluded to the product that I use for telemedicine, which is HIPAA Chat. The name is now HIPAA Bridge because it's part of Everbridge, which is a global company. But the whole mainstay of this is that it's just iMessage and FaceTime, but it's HIPAA compliant. So anything that you can do, anything you want to text or send a picture or do a dictation or do a quick video call that is exactly like a FaceTime video call is all HIPAA compliant when you're using this app. One of the things that doctors always say is, we all wish we could just use our phones, and now we can. HIPAA Chat HIPAA Bridge. I'm sorry I keep calling it that, but HIPAA Bridge is our tool to use this. So we can be compliant while offering our patients this telemedicine offering. And we can all communicate with each other via HIPAA compliant texting as well, which shouldn't be discounted because I think we all basically do it anyway in a non-compliant fashion just because it's good patient care. But we shouldn't be. We should be doing it in a HIPAA compliant manner. Anyone can download HIPAA Chat or HIPAA Bridge from the App Store or Google Play. It's a free app. It's a free download for 30 days. So you can try it out and see how you like it. Okay, we can go to our next slide. I'll touch upon really quickly this Mayo Clinic stroke trial that we did. We're talking about telemedicine here for, pink eye visits and triaging rashes and whatnot, but it's also a very important tool for major issues, kind of like what I was talking about in transfers. Patients who need to be transferred very quickly and have orders started sometimes can't be afforded that kind of opportunity because there's no one being able to triage them on the other end. It's being done via a phone call, or people are waiting on hold or for an answering service to call back. So when you can just do direct telemedicine, you're really giving your patients a big advantage. And there's no other case study that proved this more than the one that we did with Mayo Clinic. So this was a feasibility study. We just wanted to see if triaging stroke patients from the ambulance was possible, and it was. So our Mayo Clinic neurologists were able to do the NIH stroke scale while the patient was in transit, still in the ambulance. So just to give you guys an idea, if there's a stroke patient, they're losing 1.8 million brain cells per minute that they're not being treated. So every minute counts for these patients. And the way things are done right now, when a patient goes, is transported in the ambulance, they're taken to the hospital. They go in through the ER, and then the teams are called down. The neurologist is called. It may be half an hour before the neurologist answers even the text or the page and comes down to see the patient. And then there's the triage time, and then there's getting the teams set up, like the TPA teams or the OR set up. That all takes so much time, and these patients don't have time. It's precious for them. So this was the whole intent for our Mayo Clinic study. We wanted to see if we could get the neurologist to triage while the patient was still in transit. And lo and behold, we did. And we were able to save a lot of time, 7.45 minutes. Multiply that by 1.8 million brain cells, and save these patients a lot of agony and time. I mean, this was the difference between patients walking out of the hospital at the end of the visit and having to be wheeled out and never being able to speak properly again or walk. So this is priceless. The cost savings that we had, I mean, we basically, without going into too much detail, we just put an iPad in the ambulance and had HIPAA Bridge on it. The whole cost was $285 versus the $1.5 million telemedicine systems and carts that are out there. But it decreased hospital stays and complications and saved lives and brain cells. I mean, it was a priceless study. So I definitely want to touch upon that a little bit too. I don't know how many neurologists we have out there, but this is very important. Okay, we can go to our next slide. Okay, how do you roll out telemedicine to your patients in your practice? Again, everyone is going to have a slightly different way of doing this. I can tell you what works in my practice or what I like to tell people are best practices, and you guys can do it however you'd like. But, very simple thing I do is I have flyers in my office that say, hey, your doctor now offers telemedicine. And they get really excited about it. And then it goes on to say, download this app from the App Store or Google Play. It'll take you 2 minutes to sign in. It literally is very simple to sign in. It's like signing into Candy Crush on your phone. And so patients know how to do it. It's very, very simple, and it's very easy to use. We modeled it to look and feel exactly like iMessage and FaceTime. So even my 95-year-old cataract patients who FaceTime with their grandkids all the time really have no problem using it. So I find that the best way is just word of mouth and putting flyers up in your office. I also keep it in all the patient registration forms, and just to give them that announcement too. So basically I try to have my entire patient population download the app ahead of time, and then if they're in the office for some other issue, or they call the office, they wake up one morning and they have a red swollen eye and they don't know what to do, I can say, okay, well, let's do a quick HIPAA Bridge video consult, and I can triage what's going on. They're happy, I'm happy, because they didn't take up an appointment slot if they didn't need it, and I get reimbursed for the visit. So it's a win-win all across the board. We can go to the next slide. How do I track the telemedicine visits in my EHR? This is, you know, again, everyone's going to have their own way of doing things. What I find works the best, even though HIPAA Bridge we have open APIs, we are able to interface with a lot of the telemedicine, or I'm sorry, a lot of the EMR systems. I don't really like that prospect because I think it just adds too much complexity. I like how simple and easy HIPAA Bridge is to use by itself. So what I do is, just like a face-to-face visit, my technician will do the chief complaint, the history present illness, you know, put in all the information into my next-gen EMR system, and then I come in and do my 30-second video, you know, consultation with the patient, and then write down my findings and our treatment plan, all in the EMR system. So that way everything's recorded. There are many times, you know, if a patient has something like, you know, a shingles rash or something like that, I'll have them take a picture of it, and I'll put the picture in the EMR system too, just for further documentation. But there are no extra documentation guidelines for telemedicine whatsoever. It's exactly the same as an inpatient visit. So whatever you would do in the exam room, it's not recorded, and you know, there aren't special protocols. You just input the information into your EMR system the same way you would normally. A lot of people ask, does my malpractice cover telemedicine? I will tell you that I haven't run across one malpractice carrier that doesn't cover it at this point. You know, I'm sure that there are some that may not, but any of the major ones we've checked with, and they all do cover it. There's no extra premium for coverage either. It's all written in the benefits. If you're not sure, just call your malpractice carrier and ask. But again, I haven't run across one malpractice carrier that is not covering for telemedicine. We can go to the next slide. For the physicians who work in the hospital systems, you know, we all know we would love to just text orders to our nurses in the hospitals. I'm very guilty of leaving the hospital and then calling in an order protocol from the parts in the information to avoid signing into the CPOE system in the hospital. So there, I've admitted it, I'm guilty. And it's just because that system is so cumbersome and you know, it takes so long to order anything, so many clicks for any little thing. So I would love to be able to just text an order to a nurse. The Joint Commission had said before that that was not okay. But just now, last month in May, they reversed that ban on texting orders. And this was really huge for our whole health system because doctors everywhere have been celebrating. I mean, now we can text orders as long as it's on a HIPAA-compliant messaging platform, which is exactly like HIPAA Bridge. You're allowed to text your order to the nurse. Obviously, the nurse has to have HIPAA Bridge as well. And so that's where Everbridge comes in. You know, we implement the hospital system so that everyone, all the nursing staff, the pharmacy, the dietitians, everyone who works in the hospital system, social workers, has HIPAA Bridge, and you can communicate with everyone within it. We can go to the next slide. This is nothing, just a little quote from me. This is a game changer for all of us. It's better for our patient population, our working staff, and our physicians, obviously. I'm preaching to the choir here, I think. These are the Joint Commission's platform requirements, and you know, I'm not going to go through all of this because it's really very heavy stuff, but you know, basically they want a secure texting platform. So it's not okay to just text an order via iMessage on your phone. It has to be through a HIPAA-compliant platform, just like HIPAA Bridge. There needs to be secure sign-on process, encrypted messaging, delivery and read receipts, date and time stamps, customized message retention time frames, and specified contact lists for individuals authorized to receive and record orders. So there's a lot of stuff involved here, and way more than what this slide could possibly entail, but the message is that it just can't be regular texting. It has to be something like HIPAA Bridge. All right, we can go to the next slide. Okay, pretty much done here, but I wanted to end on a funny note. Use telemedicine, because only actors smile in waiting rooms. And I think this is so true. You know, no matter who you are, you hate being in a waiting room waiting for your doctor, no matter how great that doctor is. And so, you know, I hope that you guys will all appreciate this humor because it really hits home. Okay, I'm all done. I'm happy to take questions at this point. I'm sure there are many that have been piling up.
Thank you, Ranya. That was a great presentation. Really appreciate it. And this is Lisa Johnson coming in from Everbridge again. We did get a couple of questions coming in, and if anyone would like to ask a question now, you can just go to the question area and hit send to all, and then we will see that go by. So the first question I have is specifically for you, Ranya. So what percentage of your practice involves telemedicine? How often do you use it on a day-to-day basis?
You know, I try to use it for a lot of my follow-up visits that don't require a real in-depth exam. I also use it for a lot of my post-ops, not for cataract post-ops, obviously, because that needs to be, a full examination, but if I remove a lesion or do a blepharoplasty and those patients, are more comfortable at home, those are things that they can just send me a picture of and we can do a quick video visit. I can tell them what to do from there. So I don't have an exact percentage, but I'd say, it's a lot of patients. Every day I do 2 or 3 different telemedicine visits, whether it's just triaging a patient who wakes up with an issue and doesn't know whether or not they need to come in, or someone who's following up. And I just add them to the schedule just like a normal visit. So going through the workflow like we talked about, if a patient does have a sty and, I have given them the treatment protocol and in 1 week they're supposed to follow up, I give them that option to do the telemedicine visit at the time of the appointment. And they say, let's say they say yes, they go to my front desk to check out, and they're put on the schedule for 1 week for an e-visit. It's just given like a 15 or actually a 5-minute slot. It's a smaller slot with a specific color at the end of the day, for instance, or whenever it's convenient for them. My girls will actually call them just to confirm the day before, just like a regular visit, and then we'll also send a text to them on HIPAA Bridge to make sure that they're up and running. And at the time of the visit, my girls just contact the patient, they text them, and they start the conversation. Then they get them on video. They take the chief complaint history, present illness, just like I mentioned, and then they come get me. And I just do this all on like an office iPad. So between rooms or at the end of the day, they just hand me the iPad, I do the quick visit, and we're done. And then you submit a fee ticket with a GT modifier on whatever E&M code that you've used. And that's it. And I got to say, I've been very successful in getting reimbursed for these visits at 100%. It's not always, there are always little caveats, but you just have to try it and learn from there. I hope that answers your question a little bit.
And a couple others as well, so thank you.
Sure.
We do have a few more questions. So what is the capital investment to start a telemedicine program in a practice, and also the associated cost to maintain it? So we've got the medical managers online.
Yes.
So they're asking the right questions.
Yeah, I'm really glad that you guys asked this. So it's kind of a it's kind of an easy and hard question to answer. If you're an individual provider, you download the app, and that's it. It's a free app for 30 days, after which time it costs about $10 per month to have the app. So it's like 2 cups of coffee for the month. Think of it that way. Your patients get it for free. And so there's almost no, there's very, very little investment involved here. If you're part of a big group, like let's say the FemWell group, which is an excellent group of providers, those providers all have an Active Directory built in, they have a BAA signed, they have archiving and data retention, we do support. Those things involve a little bit larger contract, but it's still very minimal compared to what you'd be paying, what you think you'd be paying, for a big telemedicine cart system or whatever. It's basically because the hardware is all mobile and everyone has the hardware in their pockets, so there's very little investment. It's just the software that you're really investing in.
Thank you. And another question coming in. Patients send in their request to have a televisit because they're trying not to come into the office. So how do we fit them into the schedule? Is it okay to wait until the end of the day without a liability? And then I know you already covered this, what codes are used, which are basically the same but with a GT modifier, right?
Yeah, exactly. So like I was saying, right now patients call all day long with problems, and they don't know whether it's okay to come in or if you can call them in something. We get that all the time. And we're just, our girls at the front desk are triaging these calls on the telephone. We're not getting paid for it, and it's not good patient care because we don't really know what's going on. And so any of those calls, I've trained my girls, instead of doing the telephone call, we should be triaging the patient, and they come get me if they think it's something serious. Otherwise, if they triage and they say, okay, it's a sty, you can come in tomorrow, or okay, it's conjunctivitis, you can come in 2 days, or oh, that looks like cellulitis, you better come in right away. They triage the patients exactly the same way they do on the phone right now, except they have more information because it's via video, and we're getting reimbursed for that interaction.
Okay, great.
So that was, I'm sorry, I'll just elaborate there. So, for those types of things, I do, I have instructed my girls to do it all day long. Now, if there's a planned follow-up visit, I will usually stack them at the end of the day, but, if it's better for a patient at lunchtime or something, hey, that's fine with me because it really is like 30 seconds of my day. So I have no problem doing it in between patients for certain patients. Otherwise, yeah, like I said, like to color code it a certain way, give it a 5-minute slot, and put them all at the end of the day for follow-ups.
Okay. Can more than 2 parties be on the line at the same time?
You can do group chats, which is great when you're talking about when you're trying to explain instructions to grandpa and his daughter and his granddaughter want to be on the phone to hear what's going on. So yes, I mean you can have multiple parties on there, but to do a video call, the video call is one-to-one, exactly like FaceTime. Now we are coming out with what I call, in my layman's terms, the Brady Bunch video, which has squares of different people all doing a video call together. And that's right around the corner. But for right now, the FaceTime-like call is just one-to-one, exactly like FaceTime or Skype.
Okay. And then I think we have one last question, which I think might be more towards me. How cumbersome is the encryption function of HIPAA Bridge? Does it work both to and from the patient? So just to kind of give you a background of how the encryption works, it's the equivalent of a military-grade encryption program. So it's not just the whole conversation, it's every piece of the conversation is encrypted as it goes back and forth. And it's something as a user that you don't need to worry about at all. It just happens. All you do is log into your app, connect to the people you need to connect to, and go. It's a very simple process. One of the things that a lot of people don't know about HIPAA Bridge is that we are actually prioritized by the U.S. government for communication. So for instance, if there's a hurricane in Florida and the text lines are down, we are at the same level as FEMA for communication. So to put that in perspective, first the White House gets to text each other, then the military gets to text each other, and then it's us along with government agencies like FEMA. So it's something that can be very useful, especially if there's some kind of catastrophe going on. And I think that is about it. I do want to cover, if anyone would like a demo of this, we are more than happy to set that up for you. You can just go to everbridge.com, request a demo, and you can also stay connected with us on Twitter and on Facebook. We are at Everbridge on Twitter and the same on Facebook as well. Ranya, thank you so much for coming today and answering all of our questions and talking about billing for telemedicine. And we'd also like to thank Wendy and Jessica from the SFMGMA for being hosts for today's event. Thank you very much, everyone, and we will send out an email shortly with the recordings and the slides as well.